Uh, Welcome to the webinar on treatment options for the wear case or treatment of the worn dentition. I am Professor Paul Tipton. As you can see on the screen, I'm a professor of cosmetic and prosthodontics, and I'm president of the British Academy of Restorative Dentistry. So welcome to this webinar. We will crack off straight away. So our discussion today, our webinar today, is all about wear and the treatment. So before we get into the treatment, we need to look at a little bit about the etiology and why wear occurs. So wear will occur because of two major factors. The first factor is bruxism and the second factor is erosion. So let's look at bruxism first of all. What causes bruxism? Stress causes bruxism, and as you are all well aware at the moment, we're living in a much more stressful world. With the advent of the recent COVID-19, then everybody's more stressed. If we look at studies, we go back maybe 20 years ago, the studies would suggest that between 15%, 10 to 15% of our patients would be bruxing at any one night. I think that's gone up now, and I think more recent studies would suggest it's more likely to be 15 to 20%. In my particular practice, I would suggest it's probably more likely to be 30%. So anywhere between those percentages are the patients, number of patients who are bruxing at night time. That's clenching, that's grinding. We also know from the studies that everybody will probably clench and grind at some stage in their life. The difficulty for us as dentists is, of course, we don't know when. So we have to start thinking about treating all our patients as though they are potential bruxists. If we don't, and somebody then does go and start clenching, bruxing and grinding on our restorations, then our restorations are potentially going to fail. And the one thing that I want to teach you out there, and the one thing that is so important for restorative dentists, is the fact that we have predictability. We have predictability in our success. We want success. We want to be able to treat the patient, look the patient in the eye and say, yes, we will get a successful result. So what we're going to be doing today is sharing with you the ways in which we can get predictable end results. So we have those two factors, bruxism and erosion. Now, if you put erosion and bruxism together, then what happens is we get wear taking place more rapidly. And when wear takes place more rapidly, we can start to lose vertical dimension as well. So we're also going to talk today about vertical dimension and how we restore vertical dimension to our cases. So let's look at the signs and symptoms. And this is always very useful to do a mental audit in your own practice. So the adult patients that you see in your own practice, okay, quick mental audits, how many of them have got any, I mean any, not all, any of these signs and symptoms? So how many of them come to you on a regular basis, you know their history, and they've got a history of fractured teeth, fractured cusps, restorations that are breaking, or they've got problems with their jaw joints, they've got clicking or pain in the temporomandibular joints, or they've got a history of muscular pains, increasing amounts of headaches, maybe some migraines have been misdiagnosed as migraines when really they're muscular headaches. How many of them have got worn dentitions? Their lower incisors are wearing down, their canines are wearing down. They may have abfraction lesions at the neck of the tooth, those V-shaped non-carious lesions where we think that bruxism may play a role, or they may have periodontal problems. Now, periodontal problems, I don't mean they've got periodontal disease. What I'm talking about, how many of your patients have got recession, where there's no periodontal disease going on? How many of your patients have got maybe mobility, where there's no periodontal disease or minimal periodontal disease? So add up all of those signs and symptoms, okay? Mental audit, what percentage of patients in your practice, adults, have those? You tell me. So in the UK, where I'm lecturing from, the normal percentage would be anywhere between probably 60 to 90% of our patients. So if we can state that maybe as an average of 75%, something like that, that tells you the level of the problem that we've got. Now, the next question, which is a very, very big one, is what are you doing about it? If 75% of your patients have got these signs and symptoms, I'm going to call this occlusal disease. If 75% of your patients have got occlusal disease, then what are you doing to try to stop it, to eradicate it, and to treat it? Well, that's what we're going to be talking about today. So we've got certain ways. Let's look at our ways. We have 3 ways of treating bruxism and treating the consequences of bruxism. The first way is to try to stop the bruxism from happening. Okay, now how can we do that? Potential for that is more or less, hypnotizing somebody. So can we do anything mentally to them by hypnosis or something other like that to try to actually get them to stop clenching and grinding? Well, these studies have been tried, and the answer, of course, is no. If there was a way of doing that, then we would be doing it by now. So we cannot mentally go and treat them and stop them from bruxism. So bruxism is there. Our patients are going to brux. What's the second option? Well, our second option, therefore, is maybe to try and put something between the teeth. Okay, and if we put something between the teeth, then maybe if we do brux, we don't get damage to the teeth, we get damage to the something that we put in between. And that something that we put in between is a piece of plastic. And that piece of plastic we call an occlusal splint. So that's our second option, is to put an occlusal splint in place. Third option, and what's the problem with the second option, occlusal splint? How many patients actually enjoy wearing their occlusal splints? I make lots and lots of these. I treat a lot of patients with worn dentitions. I treat a lot of patients with TMJ problems, and we do a lot of splints. They work really, really well. However, our patients don't really enjoy wearing them. And there's a certain amount of patients that will say no to wearing them, or will say yes and then don't wear them afterwards. Third option, and this is one again which we're going to talk about in some detail, is try to reduce the amount of stress that the patient bruxes with. So reduce the forces. So number 1, stop them doing it. Number 2, piece of plastic between the teeth, so no damage. Number 3, reduce the forces. So when they do clench and brux and grind, they do it in the right area that you choose and with reduced amount of force. So let's look at our occlusal splint. There are many, many occlusal splints that people can do out there. And this lecture is not about occlusal splint therapy and how to do them. But my mode of doing occlusal splints is full coverage, hard acrylic, fully adjusted splint, so that we have the ideal occlusal form, the ideal principles of occlusion on my splint. So I'm going to talk about principles of occlusion a little bit later in the webinar, but we need to make sure that our splint is not doing any further damage. It is not just there to stop the teeth from clenching and grinding against each other. It is also there to relax muscles, and it's also there to allow the temporomandibular joints to adapt to their ideal physiological position. So the occlusal splint needs a bit of work doing on it. It is not a bite raising appliance. It is not a night guard. It is fully adjusted, hard acrylic splint. I tend to make, for our class 1 and class 2 patients, I will make an upper, a Michigan splint, as you see on the screen. For my patients who are class 2, then I will make a lower, and that is a Tanner appliance, but they are adjusted exactly the same. Nice study was done in the BDJ, British Dental Journal, 6 months to 9 months ago by Professor Nairn Wilson, and he looked at all the different types of splints, did a review, and came to the conclusions that bite raising appliances, soft splints, those sorts of splints that aren't fully adjusted full coverage can cause more damage than they can do good for the patient. So the advice there was, if you're going to do a splint and you'd want to make sure that you get success and not make the patient worse, is it's either a full coverage upper or lower splint, not partial coverage, not soft, and it has to be fully adjusted. So let's look now at the major part of this presentation, which is the restoration. So we can restore our patients in two ways. The first way is with a softer material, a plastic material. We know that is composite. And the second way is to go to a harder material, a little bit more like enamel, which will not wear down, which of course is ceramic. So let's look at the composite first of all. Now, what is our ideal? Why composite? What do we know about composite? We know that it's fairly easy and cheap to put into the mouth. The problem with it that it degrades rapidly. Under bruxing clenching forces, with erosion going on in the mouth, you can imagine a composite's going to last in the region, I'd say maximally 5 to 7 years before either it's worn down or aesthetically it needs to be replaced. But what it does give you is it gives you the ability to trial out how you want the occlusal scheme to look. Now, we're not talking a full mouth reconstruction in composite. We're talking about simple things like maybe a canine rise. So here, if we look at the screen on the left, you will see that we have a canine that's worn, and this is my patient now going into a right lateral movement, sliding over to the right-hand side. And what can you see? Well, you can see at the moment that we've got two wear facets on the canines where the canines are worn down. So she's been doing, or he has been doing this clenching and grinding for a considerable amount of time to wear down the canines. We can see that there's a wear facet on the lower central incisor here. We can see that the upper central now is on the distal aspect shorter than the lateral, which means that it's lost at least 1 millimeter of length because it should be 1 millimeter roughly longer than the lateral. We also see that all the posterior teeth now appear to be moving together as one. So our patient in this instance has probably started off with canine guidance, has ground the canine down by repeated bruxism. To this stage now is into group function. Now, what's the problem with this? The problem with this in group function now is that not only will the canine continue to grind down, but also, as you can see, the central incisors will grind down. The lateral, you can see some evidence just on the incisal ledge there, will grind down, and we'll get grinding and clenching on the back teeth. Now, that is a real problem to us. As soon as the clenching and grinding goes from the front teeth to the back teeth, the leverage in the mouth changes. What we want to do is to try to reduce the leverage in the mouth when the patient clenches and grinds. Now, you're probably all aware at school, etc., you learned about levers, the theory of levers. We have 3 types of lever. We have a class 1, a class 2, and a class 3 lever. The most detrimental in the mouth is a class 1 lever, followed by a class 2 lever. The type of lever that gives the least destruction, the least efficiency, is a class 3 lever. So what we're doing is trying to always give our patient class 3 leverage, not class 2 or not class 1 leverage when the patient clenches and grinds. When somebody bruxes, be aware of the forces involved. When somebody clenches their teeth, all of you now, clench your teeth as hard as you can together. Okay, you're probably clenching with a force of 30 to 60 pounds per square inch or Newton centimeter. Okay, if I ask you now to go and clench harder, okay, so come on, clench harder, 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 harder. Maybe you can clench harder by 1 or 2%, but not significantly. Now, remember that figure of 30 to 60 pounds per square inch. Now, when you're bruxing, it's been recorded you can brux with 300 pounds per square inch. Now, can you imagine just at the moment when I'm asking you to clench harder, come on, clench, clench, clench harder, and you can't do it, can you imagine clenching 5 to 10 times as hard? Those are the forces that are involved in bruxism. To make it worse, some studies have shown that during the normal waking day, the 16 hours when we're awake, our teeth are only in contact between 4 to maybe 12 minutes. Okay, and these are fleeting contacts. When we're chewing, when we're swallowing, okay, our teeth come into contact. Add in now that bruxism, you can brux and clench and grind for 3 to 4 hours. So it's the bruxing part that is detrimental. So with those sorts of forces, what we want to make sure is we've got class 3 leverage, not class 2 leverage. And that means allowing the patient to brux at the front of the mouth, not the back of the mouth. If the patient starts to clench and grind on back teeth, you know what happens. Back teeth fracture, or they become mobile, or we get joint problems, we get muscle problems. So we have to make sure that when we clench and brux and grind, we control it as restorative dentists. A good restorative dentist out there is a control freak. I'm a control freak. I need to control everything that's happening in my patient's mouth. If I can, then I can get that word we're after all the time, predictability. So I'm now going to treat this patient very simply with a canine rise in composite. So you can see all we've done here is restored the shape of the upper canine. I've added material onto here, re-restored it to its ideal shape, and suddenly look what happens. We now go into a right lateral movement, and straight away the front teeth are not sliding, the back teeth are not sliding. We've lifted the occlusion off the rest of the front and the back teeth. So in lateral guidance, the canines are ideal teeth. And this is something you need to be looking for all of your patients. Okay, all of us should be doing many, many canine rises per day, per week. It's the simplest thing that you can do to stop the wear from occurring. Now, sometimes the wear has got so far that we need to go and do further restorations. We need to restore the function and the aesthetics. But in simple cases like this, where the wear is starting to occur, you can see it, you examine them, and you can see that the patients may be in group function, the patients maybe got teeth at the back of the mouth coming into contact, maybe got non-working side or balancing side contacts when you examine. Those are the times when you need to put on the canine rise. Simple, simple little canine rise. That can go a little bit further to the extent where we not only put canine rises on, but we also go and restore the upper anterior teeth. And composite is a lovely material. It will wear, it will chip, it will give a little bit. And what we do a lot of, if the patient is going to have long-term ceramic, is put them into composite to start off with. It's a little bit like putting them into provisionals. Put them into composite. Do this sort of work as a starting point. Some patients may not be able to afford to go to full ceramic, in which case we keep the composite going over a longer period of time. And we know, as we mentioned, 5 to 7 years before it needs to be redone in most instances. But at least we've got the patient there and we've sorted out the occlusal problem. Now let's go and start to look at some of the longer term treatments. And for that, we're going to go to ceramic. So we're going to restore with ceramic. So the first goal of treatment is to create space. Create space for my restorations, and then go and create a reorganized occlusion. What we mean by a reorganized occlusion is a therapeutic occlusion where the joints are in the right position, the muscles are relaxed, there are no interferences, we've got canine guidance in right and left lateral, we've got protrusive guidance on the front teeth. We have our ideal occlusal form. This is not a natural dentition, this is an ideal dentition that we're creating. But our first goal is to create some space. Now, with most people who've got worn teeth, okay, so imagine, let's look at a typical case. We'll see one later on, where they've got worn lower incisor teeth, okay? When you wear your lower incisors down, when your patients come to you and present to you, they don't present with their lower incisors worn down and not in contact with their upper incisors. So as the incisal edge wears down, we have these compensatory mechanisms. These compensatory mechanisms, alveolar bone growth, cementum deposition. Okay, and that means that we get over eruption occurring. So if I've got some lower incisors which are now showing dentine, they're quite short, they're worn, and I now need to restore them, I have no space for my restorative material. So I've got to look at ways of creating space. We have several ways of creating space. We have a way of creating space all the way around the mouth, and that means increasing vertical dimension. And we have ways of making space in smaller areas of the mouth. And for that, I'm going to discuss with you our first case, which is using a Dahl appliance, D-A-H-L, Dahl. Bjorn Dahl, 1970, did the original work on Dahl appliances. Now, a Dahl appliance is an orthodontic appliance that seems to be used by restorative dentists, not by orthodontists. Okay. In another word, we would call it a biplane, anterior biplane, or something like that. And the idea is we prop the mouth open in certain areas and allow for the over eruption in other areas. So let me take you through this sort of work and how it works. So our first patient here in front of us, this patient is 45 to 50 years of age, is undergoing erosion and also bruxing. Okay, so here's the erosion taking place. Also bruxism, you can see that the incisal ledges are wearing down. Look at the notching present on that lateral. The erosion is not only affecting the labial aspects, but you can see probably from the screen that there's a large amount of blueness in some of these incisal edges and mesially. And that's from the loss of enamel and dentine on the palatal aspect. So here's our palatal view, both in the mouth and also on study models. And you can see the amount of tooth loss that's gone on with the erosion and the clenching, the bruxism in this particular instance. Our teeth are looking very, very thin. The pulps are not on show yet, but if this continues, the pulps will end up being on show. But all the time we've got the over eruption. So if I want to put some restorative material in here to get rid of the sensitivity, to make the teeth thicker back to their normal size, to stop any potential pulp or problems in the future, I need space. But my lower anterior teeth are now contacting there. So how do I get the space? So let's go through some of the options. First option, and we mustn't disregard it, is to grind down the lower incisors. Okay, sometimes the lower incisors may look over erupted. Sometimes they may have incisal edges which are worn, in which case we can move them down by 1 millimeter or something like that. So aesthetically, restoratively, it's an option. It's not an option which we do very often, but if the case is the right case, then simply level the lower incisors, and that will give you some space. So that's number one. Number two is to maybe prop open the bite at the back. So our patient, you can't see at the moment, but our patient has posterior restorations. Okay, he has amalgam restorations in most of his upper posterior teeth. So what we can do is change those amalgams to either ceramic, further amalgams. I wouldn't like to do too much in the way of posterior composites here to stabilize the occlusion, but gold work, ceramic work, further amalgams, but this time leave them a little bit higher. So the occlusal surface, instead of being deep like this on the occlusal surface, we leave the occlusal surface like that, shallower cusp angles, make the occlusal fossa slightly taller, the amalgam a little bit thicker, and that props open the bite at the front, and therefore we have space. Now, question I'm always asked, if we do it this particular way, and we do from many times, do we do the anteriors first and then prop open the back posteriors with our restorative material, or do we prop open the back first and then put the anterior restorative material in? Answer is always the same. We always do the anteriors first. And it's important to get your anterior guidance, the shape, the most comfortable shape, the phonetics etc. Get that right first of all. So the anteriors are more important than the posteriors. So get those anteriors whereby we put the composite in place first of all. We build them up, we get the correct shape, we get the guidance in protrusive and lateral movement so it's smooth and it's even. And then when we've got space at the back of the mouth because we've built up these composites, then we go and restore to the facial height that we've created on the anteriors. So always anterior restorations, anterior guidance first, then go back to your posteriors. So your second way, first way is level the lowers. Second way is go and increase at the back of the mouth, the vertical height. Third way, let's look the occlusal way. Some of our patients, 90% of our patients have a slide from retruded contact position where the condyles are in their most superior position to intercuspal position where the condyles are forwards and downwards. We call that an RCP ICP slide. 90% of our patients have got one of those. So if we took our patient back to RCP from intercuspal, manipulated them back, then that would mean again that the anterior teeth would probably be out of contact. So it all depends on the slide. If we have a slide that's only 0.5 millimeter and we take the patient back and we do an occlusal adjustment at the back of the mouth, then we'll probably gain 0.5 millimeter of space. But many of our patients have got slides which are 1, 2, 3, 4, 5 millimeters in size. So that means if we do an occlusal adjustment or equilibration on the patient, the mandible will drop backwards by approximately 1 to 5 millimeters, in which case then the anterior teeth are out of contact by 1 to 5 millimeters. Hence, you now have your space to restore. So our third way is by doing an occlusal adjustment for those patients that have large slides between RCP and ICP. Now we move on to our fourth way. And the fourth way is the way that we're going to be doing it here, which is the dial appliance. So let me show you what the dial appliance does. In this case, dial appliance and palatal veneers. The first thing we do is we decide at what vertical height we're going to work. So we just go back a couple of slides. I would imagine I need to increase vertical dimension, put probably about 2 millimeters of thickness in here. So what I'm going to do now is I'm going to mount my models around retruded axis position. So important that when you increase vertical dimension, as you're going to do here, there'll be no intercuspal position left. Therefore, you have to go and get the condyles back into RAP. So take your mounted models with the condyles in RAP or centric relation, whichever you want to call it. And then at that stage, we now increase our vertical dimension by a couple of millimeters at the incisal pin. That gives us the space to do our dial appliance. So here's our classic dial appliance. So it is now 4 palatal veneers done in nickel chromium, okay, which is our standard material. So this is the work that Dahl did back in the 70s. He used nickel chromium. He also used chrome cobalt on partial dentures to do this. Okay, but these are splinted. They're made with a ramp. You can see this horizontal ramp in place. And they're made with the horizontal ramp so that the lower incisors will hit that horizontal ramp at 90 degrees. This is really, really important, that the horizontal ramp is there to try to push the lower incisors down. So what the dial appliance does is it selectively initially creates intrusion for the lower anterior teeth, and then later on allows the upper and lower posterior teeth to over-erupt. Okay, once the dial appliance has been finished, we take the dial appliance off, and guess what? We have space between the anterior teeth because lower anteriors have intruded, posterior teeth have over-erupted. So important that to get the intrusion correct as opposed to lingualization, we have that horizontal shelf hitting the lower incisors at 90 degrees to their long axis. Second thing is that these dial appliances need to be splinted together for predictability. We come back to predictability. The reason is if you use them individually, rather than intruding the lower tooth, what can happen is the lower tooth can just gradually try and push the upper tooth forwards. Hence, splinting them will stop those upper teeth from being pushed outwards. These appliances can be made in composite if you wish. Okay, so some people like to go to the definitive restoration first of all. So go and put your composites in, splint them together. So we go back to our original patient here. So put the composites in place, get the right guidance sorted out, get the thickness, but make sure they're splinted together. Then wait for a certain amount of time for the posteriors to over-erupt and for the lower anteriors to intrude, and then go and de-splint them together. That's another way of doing it. I prefer the predictability of using the dial appliance first in nickel chromium and then going back and restoring, whichever way. So these are cemented in place with just a normal glass iron of cement, and we just wait. We now wait for the posteriors to over-erupt. So this is at the time of fitting. I've not cleaned up very well. We've got some GIC around everywhere, but you can see that the posterior teeth, the canines, etc., are out of contact. So how long will it now take for the lower incisors to intrude and for the posteriors to over-erupt? Depends on time. Depends on the age of our patient. So if our patient is, let's say, 20 to 30 years of age, this will probably occur in a month, 6 weeks. If our patient's 30 to 40, it may be 8 weeks to 10 weeks, 12 weeks. Our patient's 40 to 50, 12 weeks, 3 months, 4 months. We start to get to 50 and over. This can now be taken 6 months or even longer, in which case you have to say, is it worth it from a time point of view for our older patients to get the space this way? So it's great for younger patients, not as used as much for older patients because of the time problem. How do we know when treatment has finished? Treatment's finished by the fact that our posterior teeth have over-erupted, the posterior teeth are in contact, the posterior teeth are now holding shim stock at the back. At that stage, we take the dial appliance off and we have our lower incisors like this. And we now go and restore those lower incisors. So we can see the closing up. Look at that premolar here. To start off with, it's a millimeter out of contact, and it's now just 0.5 millimeter out of contact. If you think if I'm opening up by 2 millimeters at the front, I'm only opening up the back teeth by 1/3 of that, 2/3 of a millimeter. So I'm only asking the back teeth to over-erupt by 1 millimeter up at 1 millimeter lower. So very quickly, the back teeth will come into contact first. The last teeth to come into contact will be the ones that are closest to the dial appliance. That will be the canines. So we have to wait longer for the canines. What does the dial appliance do to TMJ? What's it do to muscles? How does the patient feel? Is it comfortable or not? These are questions we get all the time. The first answer is because it's going into the front of the mouth, then when the patient clenches and grinds, the posterior teeth get discluded. So this is a little bit like fitting a Lucia jig, an anterior splint into the patient's mouth, a semi-permanent one that's there all the time. So in fact, what we know with an anterior splints are great at reducing muscle spasm. They're reasonable for creating good TMJs, for getting rid of TMJ problem. However, they're not great because of the over-eruption. But in this case, we want the over-eruption to occur. So the dial appliance, when it's fitted in the patient's mouth, number one, is it creates a more relaxed musculature and allows the joints to go backwards up towards RAP. So very nice for treating somebody who's got minimal TMJ problems. I wouldn't treat somebody with a dial appliance if they've got severe TMJ problems. I go to an occlusal splint first, treat the TMJ problems, then maybe look at a dial appliance. But great for patients who've got muscle problems. And within probably a week or 10 days, the posterior teeth have over-erupted. Remember, I only want 1/3 of a millimeter here and 1/3 of a millimeter there. And as soon as the posterior teeth are over-erupted, Now I've got a tripod. I've got contacts at the front, contacts at the back, and the patient feels reasonably comfortable. To start off with, your patient will say, I'm struggling to eat. That's fine. Don't worry about it. You'll get easier and you'll get more comfortable as you get a little bit later on in treatment. So we now, after, in this instance, it was 3 to 4 months, we take the dial appliance off and we have space. And we have space between the upper and lower anterior teeth. You can see the wear that's been taking place on these lowers due to the clenching and grinding. We take our impressions again, and these are non-preparation porcelain veneers. And all we're going to do is bond those porcelain veneers onto the palatal aspects. So here's the palatal aspects now bonded with the porcelain veneers. Why did I use ceramic? Just for the longevity. Could have used composite, but that composite will wear. I think there's something in the science would also say that composite can sometimes wear lower incisors more than porcelain can. So your porcelain does have to be very, very highly polished. You have to polish it well. From the anterior part, nothing looks any different apart from we don't have the translucency anymore, but we've created the space to do a minimal or non-invasive procedure. So the dial appliance is a way of giving you space. Let's look at our next case. We've got several cases to show you. So our next case is, again, we're going to create the space with dial appliance, but this time we're going to use some crowns. So here's our patient, and you see straight away that he's got worn teeth. So this is his initial smile. This is his grimace. So on the left-hand side, as you look, I'm asking him to smile. Come on, give me a big smile. Smile, smile, smile. That's his guarded smile. And on the right side, I'm saying, okay, say E. Okay, really give me a big smile now. E, like that. Maximum smile. So what do we notice? We notice, number one, he's got worn teeth. Number two, we also look and see his lips are very distended. Those are not really comfortable lips. So when he's smiling, he's not used to smiling. So this is an exaggerated smile, and his lips are not relaxed when he's smiling. So if his lips aren't relaxed when he's smiling, what will happen if we go and do some restorations for him? And remember, the incisal edge position, if we're going to do some upper anterior restorations, the incisal edge position has to comply with, has to be in a good relationship with the upper lip. So if my upper and lower lips are distorted because he's not used to smiling, when he has a nice smile at the end, his lips will relax more. And that means that I may end up showing, or he may end up showing, more incisor eventually than you'd like him to for his age. So in order to get the incisal edge positions, both upper and lower, we need to have relaxed lips. In order for this gentleman to have relaxed lips, we're going to have to get him used to his smile. So he's going to have to be in his provisionals, his prototypes now, for a longer period of time, which is great. So that now allows me some time to create some space using the dial appliance principles. So this is his lips relaxed in repose. So this is him going Emma. Okay, and what you don't see, Emma, is teeth. So why do we not see teeth there? Well, this is one of the situations where you can comfortably say he's lost vertical dimension. And he's lost vertical dimension because the over eruption has not taken place to compensate for the wear. So let's look at this. We mentioned it a little bit earlier about over eruption and wear and also vertical dimension. So we have three types of patient that we will see with wear. Patient who doesn't wear his teeth at all, patient who wears his teeth at a reasonable rate, and patient who wears their teeth more rapidly or more severely. Let's look at what happens with those three patients, okay, with the compensatory mechanisms as well. So compensatory mechanisms, over eruption, cementum deposition, alveolar bone growth, go on through life. So you know that if you have a lower tooth taken out, a lower six taken out when you're young, then the opposing tooth will over-erupt. Why is it over-erupt? Compensatory mechanisms, alveolar bone growth, cementum deposition. Fine, but that is going on throughout life. So as we grind our lower teeth and they become shorter and shorter, as I mentioned, there isn't a gap that suddenly appears between them. The lower teeth over-erupt due to the compensatory mechanisms. So if we have a patient who theoretically does not grind their teeth at all throughout life, I know it may be unusual, but somebody who doesn't grind their teeth throughout life at all, then the compensatory mechanisms will still be taking place, and we will in fact have increase in vertical dimension. The lower third of the face will increase during life. This is not unusual. Noses increase as we get older, ears increase in size as we get older. So in some patients, the lower third of the face will also increase. Now, we don't see many patients in today's society who do not ever clench and grind and therefore have this increase in vertical dimension. Let's look at our second case. So our second case is the person who clenches and grinds at a physiological rate, which is similar to the compensatory mechanisms. So what's going to happen to his vertical dimension throughout life? It's going to remain more or less the same as we go throughout life. Now, we know that bruxing, clenching, and grinding is cyclical. So it doesn't happen all the time, the same amount every night. So even though the vertical dimension will stay the same like that, if we measured it very, very accurately, actually what will be happening is it will be going up and down. Okay, I'm going through a bruxing phase, so vertical dimension is going down. I'm now not bruxing because the stress has gone away, so vertical dimension will come back up again. But overall, the vertical dimension will stay the same. Now we look at the third patient, and our third patient is either the severe bruxist or the bruxist who's also got erosion taking place at the same time. And in these instances, the compensatory mechanisms cannot keep up with the rate of wear. And so what happens is we don't see in the patient's mouth here teeth, because the compensatory mechanisms have not managed to keep up with the amount of wear taking place. So if you see somebody when they go like this and there's no teeth, good indication they've lost vertical dimension. Okay, let's move on. So this is our M, this is our smile, and this is our E position. And again, imagine these lips. If I'm going to do some restorations and our patient is 50 years of age, I may be saying to myself, okay, well, where do I want the incisal edge to be? Okay, let's start thinking. Incisal edge of somebody age 50, upper incisal edge, I should be seeing maybe 0.5 millimeter, 3/4 millimeter with my lips at rest. So maybe something like this, M, and you can just see the incisal edges. Okay, fine, I've done my reconstruction. What happens now when the lips relax? When the lips relax, this lip goes up a little bit more. So with my lips relaxed and going M, suddenly I see a lot more incisal edge, which then is not right for the patient's age. Hence, we have to wait for the lips to become relaxed. Okay, we look inside, we see the patient's teeth, okay, and we can see he's a horizontal bruxist. He's been bruxing, and the bruxing is affecting his upper 10 teeth. We've decided that we're going to go and do restorations now on his upper 10 teeth. His molars aren't affected, but his clenching and grinding is affecting all of his upper 10 teeth. We've done a little bit of whitening because we're going to do some ceramic restorations. So what's our goal of treatment? Create space for my restorations, okay, and also established a reorganized occlusion. So at this stage, I think it's worth us talking about what this reorganized occlusion is. 5 principles of occlusion. Okay, so it's 5 principles of occlusion that we're looking for. Okay, the first principle of occlusion is RCP equals ICP around RAP. Now, the problem with learning occlusion, and I'm not here to teach you occlusion, it's going to take a lot longer than 1 hour and a half webinar to teach somebody occlusion. Okay, it needs days and days and days, and we do occlusion courses all the time. But in order to understand occlusion, you have to understand there's 5 principles. And one of the problems with understanding occlusion is there's 2 different languages of occlusion. The first language is the gnathological language that uses RCP, ICP, and RAP. The second one is the Pankhiman-Shiler stroke Dawson language that uses CRO, ICP, MI, CO, and CR. So we have this difference in the language and the terminology. So when I talk about RAP, it's retruded axis position. Pankhiman-Shiler talk about it, it's centric relation. When I talk about ICP, intercuspal position, Pankhiman-Shiler, they call it centric occlusion or maximum intercuspation, MI. When I talk about retruded contact position, the Pankhiman-Shiler groups, they will talk about centric related occlusion, CRO. So I'm saying RCP equals ICP around RAP. Pankhiman-Shiler will say exactly the same thing, but in different language, and they will say CRO equals CO around CR. So our first principle is to make sure that the condyles are in RAP or centric relation. With occlusion, guys, it is more to do with mechanics and engineering principles than it is to do with physiology, or not physiology, but not biochemistry, physiology, but it's more to do with mechanics. Okay, really important that it's mechanics, and it's also common sense. So occlusion is common sense, it's engineering principles, and it's mechanics. It's not too much of biology. So what I want to do is I want to get the condyle in the right position. Why? Why does the condyle want to be in the right position? Number one, mechanically, it's a good position. You wouldn't go and build a robot whereby a joint was on an inclined plane, which is what most people are walking around with. 90% of our patients walk around. If you tap up and down now, like this, your condyles are not in the ideal position. Your condyles forwards and downwards. Okay, your condyles in a position determined by your teeth, not determined by the musculature. If we want to get somebody who's got no signs and symptoms and build a dentition whereby the dentition does not wear out, we've got predictable success. First of all, get the condyles into the right position. So the condyles are in a reproducible position. They are bone braced, so when they are loaded, they're not loaded on an inclined plane. And also we've got relaxed muscles. So what is this RAP? This RAP is the most superior position of the condyle in the fossa. What do we know about it? It's been accepted as the ideal maxillomandibular relationship because it's bone braced, reproducible, and the muscles are relaxed. Here, if we look closely, we've got somebody now who I've manipulated to RAP. The condyles are in RAP, but look, he's got a contact point at the back of his mouth. What's happened here is he's had a lower tooth removed. Okay, so he's had his lower 8 removed. His upper 8 has over-erupted, and the lower 7 has contacted the over-erupting upper 8. And over a period of time, the patient's had to push his jaw forwards and forwards and forwards to stop the lower 7 from hitting the upper 8. End result now is when I take his condyles back into RAP, he has one point of contact, his RCP, between lower 7 and upper 8, and all the rest of the teeth are separated. Okay, and this is what we're talking about sometimes when we take somebody back to RAP, to RCP, and we can then restore the patient because we have space. And this is his slide. So I manipulate him back to RCP, tap him up and down, front teeth all out of contact. I ask him to squeeze together. His jaw comes forwards and upwards. His condyle comes forwards and downwards. And this is now his intercuspal position. So I want to reorganize him. Second principle, mutually protected occlusion. What do we mean by that? We mean by that the front teeth protect the back teeth and the back teeth protect the front teeth. So teeth have got certain functions to perform. Front teeth, what's the function of front teeth? Function of front teeth is to make sure that back teeth disglued when we go forwards and backwards, side to side. So that's anterior guidance. What's the function of back teeth? Function of back teeth is to make sure that when we clench heavily up and down, the back teeth take the load, not the front teeth. So front teeth protect back teeth. What happens if our front teeth aren't protecting the back teeth? So what happens if, when we're sliding from side to side, forwards and backwards, instead of the back teeth discluding, the back teeth are actually in contact? We know what happens. We get fractured cusps, we get mobility, we get wear, we get TMJ problems, we get muscle problems. So that's when the front teeth are not protecting the back teeth. What happens if back teeth aren't protecting front teeth? Or in those situations, we usually want the back teeth to hit just before the front teeth, okay, by shim stock, 10, 15 microns. If that doesn't happen and the front teeth, when we tap up and down, hit before the back teeth, okay, front teeth will start to drift forwards. You'll get diastemas. Front teeth will start to become a little bit mobile. Front teeth may complain, they may wear, they may break, the patient may get sensitivity, because in those instances, the back teeth are not protecting the front teeth. So we want to set up a mutually protected occlusion. Now, on your screen here, what do you see? You see an anterior bridge from canine to canine. And on the anterior bridge, you'll see 4 pontics, and you see the 4 pontics are strangely shaped. And the reason that they're strangely shaped, okay, normally, if you follow my arrow, the pontic should be looking like this. So we've now got an extra 2 to 3 millimeters of ceramic and ceramo-metal in there. Okay, let's try and work out why. Well, this was a class 2 Div 1 occlusal scheme. So initially when the patient came to me, they had partial dentures, and the partial dentures, the lower incisors, did not hit the upper incisors partial denture. So if I was to replace the partial denture with a traditional bridge of a traditional shape, the lower incisors would still not hit the upper pontics. So if I then went into a protrusive movement or lateral movement, then the back teeth would be doing the sliding. So what I'm doing in this instance is making the front teeth, the palatal aspects, thicker so that they actually contact the lower incisors. Now when I go into a protrusive movement, my front teeth do the sliding, my back teeth come apart. So I've created the mutually protected occlusion. And yes, I'm doing some fixed movable bridges on both sides at the back, but what I want you to look at is this. Now, will my patient accept that initially? Answer is no, because it'll feel very, very strange. So we put this in the provisional and we wait with the provisional for a period of time. And that may be 1 month, 6 weeks, 2 months, until my patient gets used to it, gets used to talking, and then it becomes just the norm in their mouth. We have to make sure that the undersurface is not a ridge lap. So the pontic is not ridge lapped like this. So we do a little bit of work on the pontic site, the tissue site, to create an ovate pontic so that the undersurface of our bridge is totally convex, so it's cleansable. And now I've created the mutually protected occlusion. Third principle, anterior guidance. Okay, definition of anterior guidance: influence of teeth, preferably anterior teeth, over mandibular movement. Okay, so close your teeth together, slide your teeth around. All of you will have an individual way in which your mandible moves. Okay, so it's almost like a thumbprint, fingerprint, DNA. Okay, it's unique to you that your mandible will move in a certain way. And the way it moves with your teeth together, okay, is determined by the shape, the position of your teeth. So anterior guidance is the influence of teeth. We put a caveat on that. We say anterior teeth because we want to make sure that we have this mutually protected occlusion, this class 3 leverage if whenever possible. So anterior guidance is the influence of teeth, preferably anterior teeth, over mandibular movement. What's posterior guidance? Well, if you just open your mouth a little bit now, separate your teeth, and move your jaw from side to side. Question, what is influencing the way your jaw moves? Okay, and of course that is now your condyles and the fossa. Okay, so posterior guidance is the influence of condyles and fossa. Anterior guidance is the influence of teeth. Now, we have certain rules, principles of occlusion, there are rules. So our rules are, let's look at anterior guidance and split it up into lateral movements and protrusive movements. Let's look at protrusive movements first of all. Protrusive movements ideally should be lower 4 incisors sliding on the palatal aspect of the upper 4 incisors, the posterior teeth discluding. Okay, occlusion simple, guys. Okay, too much is talked about it, but occlusion is simple. All we're wanting to do is get the bite right as our jaw goes forwards and backwards, get the bite right as our jaw goes from side to side, and get the bite right as we bite up and down. 3 things, that's all we really need. But for those 3 things, we have to have our rules and regulations. And remember, the rules and regulations are there so that we impart the least amount of force on our teeth or on our restorations when we clench and grind. Those are the rules of occlusion. So, protrusion, what are our rules? Lower 4 incisors on the palatal aspects of the upper 4 incisors. Simple. When we go into lateral guidance in a minute, we'll talk about canine guidance being our ideal. Simple. However, there are times when we have to change that around. Okay, so sometimes you're going to have a tooth where the tooth cannot take the stress of guidance. And in those instances, we then need to change guidance to something else. So let's just imagine I had a central incisor, which was a post crown. Do you want guidance on a post crown? The answer is no. And therefore, I would have guidance instead of on my 4 upper front teeth, on my lateral, central, no guidance on the central here because it's a post, and guidance on my lateral there. So I'd choose 3 out of the 4. Both centrals are post crowns. I'd choose 2 out of 4. 3 of my upper incisors are post crowns. I can't then have guidance on 1 lateral incisor. So I have to go back to all 4. And in that instance, we also then recommend that you have an occlusal splint for nighttime use. Let's move on to lateral guidance. Okay, ideal lateral guidance, canine guidance. Why? A big canine. Okay, it's a strong tooth. It's in the right position, the corner of the mouth. It's got a long root. It's got bags of proprioception. It's easy. It's one of the longest lasting teeth in the mouth. Okay, so all these things go to say that our canine is the ideal. When wouldn't you have canine guidance? When wouldn't the patients be able to have canine guidance? When would the canine guidance fail? Well, it would fail if it was a post crown. So there are rules as well when we don't put guidance on a tooth, whether it's a canine in lateral or a tooth in protrusive. Okay, we don't. So general rule, we don't have guidance on a tooth which is a post crown, which is root filled, which is mobile, which is a pontic. We don't have guidance on a single tooth implant. Okay, fine if the implants are splinted together, but on a single tooth implant or on a tooth that has a large core. And we're talking now minimal amounts of tooth tissue, large core. Okay, why? Well, imagine what you're doing when you are putting the guidance onto certain teeth. So you are doing your diagnosis, you're doing your treatment planning, and you're saying to yourself, okay, I want my guidance in lateral aspect to be on the canine, in protrusion to be on the central incisors, etc. When do you go into anterior guidance? This is what you're determining, your treatment planning, executing for your patient now, that this is where your anterior guidance is going to be. So question, when do you go into anterior guidance? Do you, after this webinar, think, I'll go make a cup of coffee, I'll have a cup of coffee, I may go out and have a smoke, and I'll go into guidance for 2 minutes? No, that doesn't happen, does it? Do you go into guidance when you are chewing? Yes, you might do, but remember that when you're chewing during the daytime, the forces are like this. And add up all those forces, it comes to your teeth being in contact 4 to 12 minutes. That doesn't really matter. When you go into guidance is at nighttime when you are bruxing, and patients can be bruxing for up to 3 to 4 hours. Like that for 3 to 4 hours. That's when you go into guidance. So when you say to the patient, in your mind, treatment planning, I'm going to put your guidance there, what you're actually saying to your patient is, I'm going to allow you tonight to brux on that tooth and that tooth and that tooth, but not this tooth, and this tooth. So you are choosing the teeth which you are going to allow the patient to brux on. 3 to 4 hours of up to 300 pounds per square inch. Do you think a post crown can take that force? Absolutely no. So ideally, When we're choosing teeth in guidance, we're looking for two factors. Okay, we want the teeth to be as far forwards as possible, so the leverage is the least, it's class 3 leverage. And we want the teeth to be as strong and healthy as possible. Now, we all work with denticians where this sometimes doesn't happen. With the patient you saw earlier, I put guidance on the upper 4 pontics in protrusion. Okay, I'm going against my rules. Yes, I have my rules there. Sometimes we have to break them. But ideally, if I can, I want my guidance on good, strong, healthy teeth. When canines wear, as you can see here, what happens is we tend to drop onto our normal group function. Next one is I don't want any non-working side interferences or balancing side contacts. Why? That creates class 2 leverage. Sometimes it creates class 1 leverage. Class 2 leverage will fracture teeth, fracture crowns, wear teeth down. Class 1 leverage usually means the patient ends up with joint or muscle pains. So non-working side interferences can cause class 2 leverage, class 1 leverage. So we don't want it. Okay, let's look at a case. Let's look at a case now where, similar to a previous case I showed you, where we did a canine rise, this patient has got, again, worn canines. We can see, similar to the previous patient, where the anterior teeth are wearing down, but at the moment, she's 40 years of age. This has been happening slowly over the last 25 years. So she's lost this amount of tooth tissue over 25 years, okay? But at some stage, when the anteriors start to wear flatter and flatter and flatter, the posteriors will come into contact when we grind from side to side. So we'll go at some stage from class 3 leverage into class 2 leverage. So I advised this patient again to come and have a canine rise. She went away. She eventually came back and saw me around about 10 years later. And this is how her teeth then looked. So this is our same patient. Far more wear now on the centrals, laterals, and canines, but look what's happened to the premolars. They've been restored with some amalgams. They've fractured off at gum level. Why is that? Why is that? Is because of the increase in force when you've gone from class 3 leverage to class 2 leverage. So all that clenching and grinding in class 3, yes, the canines wore down slowly, but it gives you the opportunity to go and build up a canine rise and keep your patient going. But when we get into class 2, all hell breaks out. And that's when the wear suddenly becomes very, very rapid. So no non-working side interferences. Our final principle, posterior stability. And with that, what we mean is creating good tripodized contacts at the back of the mouth. So we've got at least 3 points of contact for stability on all the posterior teeth, and we've got cusp to fossa relationships. I've spent 15 minutes going through occlusion, okay? You need to spend 5 or 6 days going through occlusion to really get to the grips of it. But it should be understandable. All we're trying to do, get the bite right like that. We have rules. Get the bite right forwards and backwards. We have rules. Get the bite right from side to side. We have rules. Understand the rules. Those are the 5 principles of occlusion. Let's move on. So we're back to our patient. So we're going to do some work for him. Initially, I've done some smile imaging so he can see what the teeth are going to look like. Our goal, create space, create a reorganized occlusion. If I can do, I'm going to create a class 1 occlusion. Why do I want to create a class 1? Because that will give me good ability to have anterior guidance. And remember, if I'm going to increase my vertical dimension, okay, so I've got somebody here who I've diagnosed as lost vertical dimension. When we increase his vertical dimension, what happens to his occlusal relationship? He goes from a class 3 into a class 1. So as I increase him from here to here, that then allows me to bring the upper anteriors down to create vertical and horizontal overlap. So it's essential to this case that we're going to be increasing vertical dimension. So we do our diagnostic wax up, upper 10 teeth, prototypes, upper 10 teeth. Here we are with the wax up and the prototypes. We then go to the mouth and we put our new prototypes in place. The prototypes will increase vertical dimension because I've done minimum preparation at the back of the mouth. You can see here at the back of the teeth, this is all enamel. So all I've done is prepare a margin on the palatal aspects. Otherwise, the palatal concavities are exactly as they were. I've minimized my tooth preparation a little bit kinder because I'm going to put excessive material on the palatal aspect and open up the bite. That's what I'm going to do with my doll. So my doll is going to be from 5 to 5. When it goes into place, the molars will be out of contact. And I'm going to allow the molars now to over-erupt. Okay, 50 years of age. How long will that take? Probably 2 to 3 months. But it also gives him 2 to 3 months of having some nice provisionals in his mouth where his lips can start to relax and he can start to smile more easily. Once he's got relaxed lips, he's smiling more easily, I can now go and choose where my incisal edges should be. So here we are, increased vertical dimension. We've created a class 1 occlusion. We've created the 5 principles of occlusion. Look at his lips now. This is 2 to 3 months later. Lips a lot more relaxed. We're working out where his incisal edges should be. And we've got him where his smile, his imaging, and his definitive restoration's about to go in. So these are the definitive restorations, ceramic restorations, and they go in place. We create the guidance that we want, protrusive on the 4 front ones, lateral guidance on the 2 canines. But he is a big clencher and grinder, so we are going to give him an occlusal splint at the end. And that's how we treat somebody using doll appliances, where we don't want to just open up the whole vertical dimension, restore everything. In that instance, it was just 5 to 5. First was 4 teeth, second 10 teeth. Now let's look at increasing the whole jaw, the whole vertical dimension. And this is now restoring every single tooth. So we're going to do a full mouth reconstruction now. A couple of cases to show you. The first case is where we've got somebody with worn upper anteriors. This is his retruded contact position. Again, Goza therapy, create space. How am I going to create space? Opening him up. Remember, at the moment, he looks as though he's a bit class 3. When I open him up, what happens to his anterior tooth relationships? They go class 1. So it allows me to bring the upper anteriors down. This is what we're going to do in this case. Open him up, create a class 1 occlusal scheme, and then go and put our 5 principles of occlusion in place. We're doing some bridge work for this gentleman. This is a prosthodontic technique called Duralay copings and coat hanger wire. It's a way of taking a definitive impression that's a little bit more accurate. We've trimmed down the lower incisors in this area. As you can see from original, the lower incisors a little bit over erupted because he's class 3. Okay, and so we're trimming them down to get them to a nicer level. Also gives us a little bit more space so we don't have to open up quite as much. Upper impressions, prototypes in place, and the definitive crown and bridge work. Okay, and what's it do? Open up the vertical dimension, create a class 1 occlusion, get the correct guidance in protrusive and lateral. And now we've got protrusive guidance on upper right central, upper right canine, so upper right central, upper right lateral, upper left canine, and we've got lateral guidance, upper right canine, upper left canine. Let's show you how we treatment plan this case. And this is an important fact, and this is one of the most important parts of it, how we actually go through treatment planning. First thing is choosing the correct vertical dimension. We've got 4 vertical dimensions we can work at. Okay, first one is use the existing vertical. Now, if you're going to do a full mouth reconstruction, that is a bit counterintuitive, because if you're going to use the existing vertical, okay, and I want to do some lower incisal crowns because they're worn down, they don't look very nice, I'm going to have to take 2 millimeters off the incisal edge so I can put 2 millimeters of porcelain back. Counterintuitive, because at the end of the day, you've got somebody who's worn the teeth and you're going to wear them down even more rapidly. That doesn't sound right. So I won't say never, but 99% of times when we're going to do a full mouth reconstruction, we will choose to open up the vertical dimension. And what does that mean? It means that we don't have to do as much, or we don't do any incisal edge reduction, palatal reduction, occlusal surface reduction, because we've gained the space for that. So let's look at the three different verticals we can choose. The first one is arbitrary, and the first one involves you and your technician sitting down together, opening up the vertical dimension so that you are either eliminating or minimizing the amount of tooth destruction on the occlusal surfaces and the incisal edges. So this is allowing your technician to do an additive or near additive wax up. And that's for you and him to decide. Our second vertical we can choose is RCP. Take your patient's condyles back to RAP, manipulate him back. Okay, you saw some pictures earlier of the RCP ICP slide. When you take somebody back to RCP, 90% of our patients have a slide. That means that there will be space between all the rest of the teeth. It may be significant, it may not be. But it also means that you've increased vertical dimension when you take them back to RCP. So if you take somebody back to RCP and that creates some space, then maintain the patient in that RCP position and restore all the rest of the teeth. Now, what's useful about that RCP? It means I've got a stable contact every single time. So it means I've got predictability of working to that exact RCP position. Also means, of course, that the condyles are in RAP. That's a given. But it does mean that I've got a reproducible position. If I increase somebody just, as in the first case, minimum prep, I've got nothing accurately to work to. I've got no definitive contact position to work to. So I say I'm going to work 3 millimeters open on the articulator. It will end up maybe 3.5, 2.5 millimeters, who knows, because I've got no vertical stop to work at. If I'm working to RCP, I have a vertical stop. Final one, facial aesthetics. And this is the case, this is the way that I do most of them. So we know from facial aesthetics that certain faces have got nice characteristics. Okay, what's a good characteristic? Good characteristics are symmetry across the midline and proportion of the face. Proportion of the face says that hairline to bridge of nose to base of nose to chin should be equal thirds. So with most patients who have lost vertical dimension, it means that their nose-chin distance is less than it should be. Okay, let's look at Ivor here. So the first thing you look at Ivor, you would say that he's 55 years of age. His skin tone doesn't look very well. You say he looks a bit overweight. Lower third of the face a bit scrunched in, very wide lower third of the face. I think you'd probably say, you know, without seeing his teeth, what his teeth would look like. Okay, and these are what his teeth are going to look like. Okay, very worn down. And you'd say that he's probably lost vertical dimension. So before we start on the restorations, okay, first thing is always go and choose your vertical dimension. So a full mouth reconstruction, let us choose the vertical dimension we're going to work out first of all. That's point number one. And we're going to use, in this instance, facial aesthetics. So how do we do this? Simple. We go and mark where the hairline is, bridge of nose, base of nose, and chin, and we measure. And what we're trying to do now is put the lower third so it's equal to the middle third. Okay, not too much upper third. We can't do anything about the upper third and middle third, but we can make the lower third equal to the middle third. So this is the middle third I'm concentrating on, and that will put this lower third of the face in proportion. So with Ivor, our middle third of the face is about 45 millimeters. Lower third of the face is around about 38, 39 millimeters. So he appears overclosed by about 5 to 6 millimeters. So how do we do this? First of all, get a horseshoe piece of wax. So roll some wax up into a nice horseshoe, nice and thick, put it onto the top teeth, lie your patient back. Manipulate your patient now so his lower teeth hit the wax. Don't go all the way through it, just hit. So you've got indentations one side, indentations the other side, and a great big thick wax ring. Take it out of the mouth, put it into some cold water. Cold water hardens it. Sit Ivor up now. Put the wax back in and ask him just to gently close and find those indentations. Now ask him to bring his lips together. Okay, and he's going to look a little bit like this. Lower third of the face too long now. Now we measure. Remember, we want 45. What we've got now, we've got 49. Okay, Ivor, squeeze, stop, measure, 47. Squeeze, stop, measure, 46. Squeeze, stop, measure, 45. Okay, now either we've got 45 millimeters. Now we ask him, see what you think. We've now increased, so his lower third is equal to the middle third. And we ask the patient, okay, see what you think. At this stage, it's a good idea for him to bring somebody with him, his wife, girlfriend, something like that. Because we all know that the first time that we may have a new haircut, or ladies, you may change the color of your hair. The first time it's done, you'll look in the mirror and you'll go, oh my God, what have I done? I'm not sure. And it then takes a little bit of time for other people to compliment you, for you to get used to your new look. So we need somebody there to help Ivor with his choice of whether this is right for him or not. Because even if it looks brilliant, Ivor's so used to looking at himself over clothes that he just thinks, well, I'm not sure. We now go and give him that piece of wax, take it away for a week, Ivor, keep it in the fridge so it's nice and cold, it doesn't just all sag, and use it. And then when you come back to see me, we'll decide if we're going to work at that vertical or we're just going to reduce it a little bit more. We don't have to work at that vertical. We're just trying to improve his facial aesthetics. So we're going to increase vertical dimension. What do we do? Well, first of all, we get our mounted study casts. What do we know about vertical dimension? It's dynamic. As long as we've got rules again, we have to have our patient in RAP, centric relation. We can't increase vertical dimension around intercuspal, because as soon as you've opened the patient up, there's no intercuspal there. So we have to have our condyles in the right position first of all. Okay, it's dynamic, and we know that the first time our patient's teeth touch together, a new freeway space is set up. We also know that when we increase somebody's vertical dimension, we have to think about occlusal planes, because facial aesthetics and occlusal planes will determine whereabouts or how we open up that vertical dimension. And we can do it several ways aesthetically. We also know that if we increase somebody, that most other people will look and say the patient looks more attractive. Usually the patient looks more youthful, looks younger. So one of the reasons to do this is to not only give a great smile to somebody, but to make the patient look younger and more attractive. And to gain a noticeable change, we need to increase about 5 millimeters. Now, that doesn't mean that people will wander around saying, you've got a great vertical dimension there. Your increase in vertical dimension really suits you. No, people aren't going to know that, are they? What they're going to say in their own mind, whether they say it verbally, just think it, when somebody's had that increase in vertical, they're going to think to themselves, he looks really good at the moment. Oh, he might have lost some weight. He might have been on holiday. Okay, he looks really, really good. So that's what we're looking for. We're looking for that boost. And we know from all our studies that even if we invade freeway space, as long as we're working around RAP, then a new muscle engram will be set up instantaneously when we close together. Now, word of warning, this is all about dentate patients. We cannot increase vertical dimension like this on edentulous patients. And the reason being that edentulous patients do not have proprioception. Okay, it's the teeth. It's the teeth that when they meet for that first time, tell the muscles, this is my new position. The muscles then say, okay, let's just create a new freeway space. Okay, let's work around this. If you don't have teeth, you don't have proprioception. And we all know what happens if you increase vertical dimension on somebody who's got full dentures. Very often the patient walks back in saying, these don't feel right. I feel uncomfortable. I've got a mouthful, too much tooth. I can't open my mouth wide enough. They are giving me pain. I can't chew my food. All of these problems because we are lacking the proprioception. So this can only work, this vertical dimension can only work when we have proprioception and teeth. So let's look at Ivor again. And here's Ivor. So we now need to think, if we're going to increase vertical dimension, we're going to have some space. Okay. If we have the space, whereabouts in that space are we going to put the teeth? Okay. So if I've got now that much space, okay, I'm going to fill it with teeth. Whereabouts am I going to put the occlusal planes? So let's go back to dentures and let's go back to doing bite blocks and doing the bite for full dentures. Okay, first impressions done, second impressions done. We now got bite blocks. So question to you all, do you do the upper bite block or lower bite block first? Which one? Come on, think about it. Okay, well, let's try and make a decision. What we're trying to do when we do our bite blocks is create occlusal planes, an anterior occlusal plane, a posterior occlusal plane. What do we know about occlusal planes? Occlusal planes have got curves, okay? Posterior occlusal planes, you know they're called the curve of Spey that goes anteroposterior, curve of Wilson that goes buccolingual. Add them all together, called the curve of Monson, okay? So remember, we've got those curves, and that's what we're trying to reproduce. We have a curve in the lower, we have a matching curve in the upper. Is there anywhere in the mouth? So let's think about that curve of Spey. That curve of Spey goes, where's it go? Canine cusp tip, premolar cusp, molar, molar, molar. Ends up, it goes through, passes through the retromolar pads, big point, and ends up in the center of rotation of the condyles. If I want to create somebody's as close to their occlusal plane as possible, an ideal occlusal plane, and my teeth are worn down, I have no tooth determinants to where the occlusal plane should be. But I know it goes through the retromolar pads. So always do the lower bite block first, because the only areas of the mouth that we know are true occlusal planes originally went through that are not to do with teeth are the retromolar pads. And of course, they're only in the lower jaw. So we do the lower bite block first of all. And for a plane, for an occlusal plane, we need 3 points, 2 posterior, 1 anterior. So the 2 posterior reference points for our occlusal plane are the retromolar pads. And it's about half to 2/3 of the way up them. And it's because they're the only landmarks that stay the same irrespective of tooth loss or bone loss. What about the anterior determinant? Remember, we need 3 planes. Again, we go to our denture textbooks. Okay, when I go M, I should show a certain amount of tooth. So my anterior reference point will be my M position, and my M position with age. So I want to be able to show the correct amount of upper and lower tooth. Now, what do we know about that? As we're young, we see lots of upper tooth, we see minimal lower tooth. As we age, our lips drop down, we see less upper and more lower tooth. So Ivor's 55 years of age. Do we want to give him the appearance of a 55-year-old smile? Well, let's ask Ivor. Would you want your teeth to look like a 55-year-old Ivor, or would you like your teeth to look a little bit younger? Because hopefully we're going to do something facially to knock a few years off. Okay, please. So rather than being 55, let's go and give his teeth the appearance of maybe 45 or 50. So lower incisal edge, question to you again. Lower incisal edge, the average 55-year-old, how much lower incisal edge should you show? Answer, 3 millimeters. Okay, 45-year-old, how much lower incisal edge should you show? Answer, 2.25 millimeters. So we're going to now give him 2.25 millimeters of lower incisal edge on show when he goes M. And that's going to be his aesthetic component to the 3rd reference point. Okay, so we got our 2 posteriors. We now need to create an anterior. For that, we go back to the lips. So we take a perio probe. Ivor, go M. Okay, which he's doing. Take a perio probe. We now take a perio probe and we probe behind the lower lip, and we probe down to where we find 1 lower incisal edge. Doesn't matter if it's the central, the right central, the left central, doesn't matter. 1 lower incisal edge. Okay, perio probe. So you can now probe and you know how far behind the lip that incisal edge is. Let us just suggest it is 2 millimeters below the lower lip. So what we're going to do now is that lower incisal edge needs to come up 2 millimeters, and then we need to add 2.25 millimeters onto it to create my ideal plane. So I now go to my technician and I say, Mr. Technician, I want you to wax up 1 lower incisor only, 2 millimeters plus the 2.25, 4.25 millimeters above the lower, above the incisal edge as it is at the moment. So that now gives me my third reference point. So I have my 3 reference points. At the moment, it's a flat plane. I've not introduced any curves, but at least I have my 3 reference points for my lower occlusal plane. So what I'm going to do now, I've mounted my study cast at the correct vertical dimension with that piece of wax in place. Okay, I'm taking a rubber band, and with my rubber band, I'm moving the rubber band so that as I move it up and down at the back and up and down at the front, it is now passing about 4 millimeters-ish over the lower left central incisor as I look from the side, and it's going roughly about halfway through my retromolar pad as I look from the side. And now straight away, I can see where my anticipated occlusal plane is going to go. Now I'm going to have a curve on it, and that is just flat at the moment, but at least it gives me some treatment planning ideas. And what do I see? I see that the patient's missing lower teeth, and we've got over eruption taking place. Patient's missing lower tooth, over eruption. So I'm going to have to deal with that over eruption. I'm going to have to go and get those upper teeth pushed back up again. How do I do that? Well, that's going to be in your treatment planning. We could take the teeth out. We could put implants in. We might take the teeth out and do a bridge. We might go and do endo. We might be able to do this with periosurgery, crown lengthening, and crowns. We've got various ways of doing this. This is not the talk today. The talk today is about planning how to do it. So next thing, I'll take the rubber band away and I'll just use a pencil. And now I can see it in a pencil. Next stage I'm going to do is grind the teeth away on the upper. This won't be what I'm going to do in the mouth. This is just giving me more space than I need. So I can now create my ideal lower occlusal plane. For that, I need this. This is a Boyle's plane analyzer. Boyle's plane analyzer, you get this from denture technicians, piece of plastic, simple piece of plastic. But the piece of plastic has got the ideal, or the anatomical average, I should say, curve of Spey, curve of Wilson built into it. So it's a curved piece of plastic. And all I'm going to do is I'm going to put that curved piece of plastic, I'm going to rest it on the one incisal edge I've asked my technician to build up. Remember, one lower, in this instance, lower left central incisor, build it up by 4.25 millimeters. I'm going to rest the Boyle's plane analyzer on that tooth and rest it on the retromolar pads, 2/3 of the way up the retromolar pads. And I'm now going to build all the waxed up teeth to the undersurface of it. Okay, so here all the waxed up lower teeth now have been built up to the undersurface of this Boyle's plane analyzer. And what does this give me? This gives me my anatomical average curve of Spey. This gives me my anterior aesthetic occlusal plane. So I've done my lower wax up first of all. That's created the right aesthetics and given me an anatomical average curve of Spey. So I've created my occlusal plane from the science, not Mr. Technician create something for me. We've done it from the science because we've got predictability. So next stage is let's go and do the upper. So initially I've just done a little bit of red lines here and grinding. So I'm doing a little bit of crown lengthening on my models. And now we're going to go to the lips again. So remember, Ivor wants to be 45 years of age, 45 to 50. So the question again is, 55-year-old, how much upper tooth does he show with his lips at rest? Answer, nothing. 50-year-old, how much does he show? 1/4 millimeter. 45-year-old, how much does he show? 0.5 millimeter. So what I want to do now is create that 0.5 millimeter of show when the patient just is at rest. So perio probe again underneath the upper lip, find out where the incisal edge of the upper incisor is, measure down to the lip. So let's just say his upper central incisors are again 2 millimeters underneath his lip. So add 2 millimeters plus 1/2. Mr. Technician, wax up your upper 2-1-1-2 and the canine so that they are now at that level. So wax up central incisor first of all, which is going to be 2.5 millimeters longer. That is now the incisal plane to work to. Wax the other central to that. Wax the lateral so they may be 0.5 millimeter shorter. Wax the canine so they're the same length. We've now waxed up the upper anterior plane to the aesthetic requirements. But the teeth are still out of contact. So I'm now going to wax up the upper palatal aspects, so the upper palatals are actually in contact with the lowers. And then we just wax up the upper posteriors down to the lower posteriors. So we've now got my full mouth reconstruction done in wax at the correct facial aesthetic vertical, with the correct smile, the correct incisal planes, the correct guidance, the correct anterior tooth contacts. All I have to do now is replicate that in prototypes in the mouth and then copy the prototypes. But this is the most important part of the whole case. So there I am, finished wax up, and all we do is we go and change that into our definitives. So this is Ivor at the end. Tell me what you think. Does Ivor look a little bit healthier, a little bit younger? Does his skin tone look a little bit better? He's got some nice looking upper anterior teeth there now. And when he smiles, he just shows enough tooth. So for me, big change. Not only has he got a nice smile, but his face has got better. He looks younger and healthier. Okay, final case. So we're going to be finishing about 5-10 minutes. Final case. Talked about vertical dimension a lot in this webinar. Talked about increasing it. Talked about the rules and regulations. Go back and listen again and again and again. Make sure you understand the rules and regulations that we have to go through to get predictable response. Okay. Last case is somebody the opposite. We're going to decrease vertical dimension. Okay. So again, somebody who got different signs and symptoms. So let's look at this lady. She comes to me wanting an aesthetic makeover, typical of my patients who I normally see. They're sort of 50 to 60 years of age. They're women of a certain age who need a boost. So they're going to come and have their dentistry done. She wants a new smile. Okay. But she also says, I have got TMJ problems. She doesn't say that, but I suffer from headaches. Examine her, she's got a clicking joint, but she's got these chronic headaches, which she's had for years and years. So why she got the headaches? And we can't say just from looking at the teeth, but there is a reasonable idea here as to why she had her headaches. Look at her smile and look at the intercuspal position. Okay, what's the problem? And look at the fact that she's grinding her teeth. Okay, you can see that she's grinding her teeth. Look at the canines worn down there. Okay, so she's a clencher and grinder. She's a bruxer, but she's bruxing, clenching, grinding in what leverage? Okay, she's not clenching and grinding too much on her front teeth because she's edge to edge. So when she moves out laterally, forwards and backwards, all the grinding's coming from the back teeth. Class 2 leverage. Class 2 leverage is creating stress in the muscles and the joints. So I need to go and give her a nice smile, but I also need to treat her occlusally. How am I going to treat her occlusally? I need to give her overbite and overjet. If I can give her overbite and overjet, remember she's here. If I can get her to there, that would be my ideal, to go and get lower incisors hitting into the cingulum. So I've got lots of guidance, okay? But she's here. If I can't get her to there, at least can I get her to here to get some form of guidance in place? So that's going to be my goal. So let's start off with some mounted study casts. And what does a mounted study cast show us? First of all, it shows us that retruded contact position is on her second molar teeth. It shows us that she's got a slide from retruded contact into intercuspal. Intercuspal is edge to edge, remember. Look there, intercuspal, edge to edge. You can see it. In retruded here, you can see that the space, there's horizontal and vertical space here. So my thought process now is, what will happen? Okay, come through this case with me. What will happen if we decrease vertical dimension at the back of the mouth? What will happen if I do an occlusal adjustment at the back of the mouth to slowly, she's here, okay, in retruded contact position, to slowly bring those teeth together. As I reduce vertical dimension, okay, then these teeth will come together. They'll come together and they'll create a little bit of horizontal and vertical overlap because I'm getting rid of the slide. So again, anterior view in retruded contact. So what I'm going to do is not just adjust the models, I'm pindex the model. You can see a line there and a line there. So I pindex the model so I can take out the posterior segments. And that's the same as me doing the occlusal adjustment without damaging the teeth. So I've taken out the posterior segments. This is now the anterior tooth relationships. I'm now going to do a little bit of adjustment on the teeth, because remember, I'm going to be putting some restorations on these teeth. Okay, so I'm going to do a little bit of adjustment on these teeth. And this is, okay, the final anterior tooth relationship that I'm going to get. Let's just go back one. Okay, so I've gone from there to there. Now, listen, I've got a little bit of overbite and overjet. I've gone from here to I've got some minimal overbite and overjet now, and that's just by taking my condyles back to RAP. That's just doing an occlusal adjustment. I've done it on the models first, so I can see my end result before I go and do it in the mouth. So I'm going to go and do this in the mouth, do my occlusal adjustment, get to my new vertical dimension, and then I'm going to restore. And when I restore my upper anteriors, I'm going to make them a little bit further forwards to give more lip support and a little bit longer. So I'll get even more incisal overlap, which gives me more anterior guidance. So we've reduced vertical dimension by about 5 millimeters in this case. I'm now going to do my wax up. Okay, the reconstruction will be all the upper teeth and the lower posterior teeth. We're going to keep the lower 6 or 7 anterior teeth as they are. So I've done my wax up, my prototypes, my preparation guides. Into the mouth, preparing the teeth. These are going to have Emax restorations. Again, as before, preparing with less preparation on the palatal, so we can actually move these teeth a little bit further forwards. Silver dyes, could speak to you for half an hour to an hour on the benefits of silver dyes. So I won't say all now, 90% of all the work I do is done on silver dyes. So I take my initial impression, my addition cured silicone, and my technician silver plates the impression. End result is I get silver dyes. Advantage of silver dyes, you can take a sharp instrument over those margins for the next 5 years and you can't damage them because they're silver. If this is a stone die, you can damage margins. So there's my final reconstruction of the upper, just some Emax crowns. Okay, and there's the smile. But what we've done, we've created overlap. We've created our 5 principles of occlusion. So we increase vertical dimension a lot with wear cases. Sometimes you have to think outside the box and you may decrease, but all the time you're going for those 5 principles. And the 5 principles are there to take the stress out of the masticatory system when your patient clenches and grinds. And that means you have a more comfortable dentition, you have a dentition that lasts longer and is protected. And in terms of protection, we're putting an occlusal splint in place as well. So guys, thank you very, very much for listening to this. I know that we've run over, but this is a long webinar to listen to. I'm doing a series of webinars through Tipton Training. So my company back in the UK is Tipton Training Limited. This is the website address, www.tiptontraining.co.uk. Please go and visit that particular website address and register. We do webinars every single day. So my faculty and myself are doing webinars every day. Some days we're doing 2 webinars, one in the morning, one in the afternoon. They're completely free of charge. We're putting this on for the dental profession worldwide, free of charge, to help people through the COVID-19 problems. I have a lot of friends in India. What you may not know about me is I used to be a professional cricketer. I played for Lancashire County Cricket Club with many, many Indian friends. So please come and visit Tipton Training website, register, and you'll get your free webinars. Thank you very much indeed.
Questions.
We have some questions, which we're going to share with you just now. Okay, so the questions are on the screen. Okay, Abhishek, I see you're up there first of all. Okay, question. What composite do you use for canine rise? How much to raise the vertical dimension? How you decide? Okay, so first question. What composite do I use for canine rise? I use Venus Pearl is my particular composite that I like to use. It's just a traditional composite. It's not a flowable. It's not anything that's particularly different about it. Just a standard composite that you'd normally use for any of your anterior work. Next question, how much to raise the vertical dimension? How do I decide? I'm hopefully gone through that. We decide how much to increase vertical dimension either by just being pragmatic and saying to our technician, let's try and increase so we do a minimum restorative destruction of the incisal edges and occlusal surfaces. So we do an additive wax up, which minimizes the amount of destruction that we do during our full mouth reconstruction phase. That's one way. Second way, work to retruded contact position. Why? Because we have a definite stop. Third way, and the way I use most of the time, is facial aesthetics. So we put that piece of wax in, we get the ideal facial aesthetics, we get our mounted models at that height, we do our wax up at that height, our prototypes at that height, we prepare and put the prototypes in at that height. So hopefully I've answered that question. Next question, doll appliance. How can we control which teeth move? So we know from doll appliances, it's been around for a long, long period of time, lowers intrude and posteriors over erupt. Okay, the lowers intrude initially, so the initial first movement you get is the lowers intruding. The second is the posterior over eruption. One word of warning about the posterior over eruption. What do we know about posterior over eruption? First of all, understand that uppers and lowers do not over erupt vertically. Okay, what uppers and lowers do, imagine this is now my upper teeth. Well, let's start off with lowers. Okay, lower buccal, lower lingual cusp, lower buccal cusp. This is a lower 6. Okay, lower right 6. When this over erupts, it doesn't do that. When this over erupts, that happens. So it tilts to the lingual. When upper teeth over erupt, okay, they tilt out to the buccal. And what happens when that occurs is the buccal cusp gets taller. The palatal cusp gets taller and it changes cusp angles. So if we get over eruption, there is a greater chance because of this tilting that we're going to have a non-working side or balancing side contact that's introduced. So at the end of the doll appliance treatment, we must always go back and look to see if we've not introduced inadvertently a balancing side or non-working side interference. And sometimes you may need to do some occlusal adjustment at the back of the mouth or some more occlusal restorations to get rid of those posterior interferences which you've created. Okay, next question. Is bleaching recommended for bruxers? No problem. No problem with bleaching for bruxers. I have no problem doing that. Next one, let's just try and get down here. Okay, next question. While chewing movements are outside in, while guidance we create are inside out, did this create any issues? No, for my guidance, we're talking about grinding from side to side, up and down. So I know we talk about guidance being like this, so going from intercuspal to cusp tip, but then we go back up to intercuspal again. So no, our clenching and grinding is side to side, forwards and backwards, from in cusp tip on palatal aspect to incisal edge and back up again. So it's the same thing, whether it's a movement from in to out or out to in. What we want to do is make sure that it's a comfortable movement. We want to make sure that it's discluding the posteriors by just enough. And this is all now about in terms of the guidance. Okay, we can have canine guidance. So this is my upper, this is my lower canine. Okay, you can have canine guidance that looks like that. You can have canine guidance that looks like that. You can have canine guidance that looks like this. So it's also a matter of talking about the steepness of your canine guidance. You want to make sure that your canine guidance is steep enough to disclude posteriors. And this is all to do with posterior cusp angles. If you've got over erupted teeth at the back of the mouth and they've tilted, it means your cusp angles are steeper. It means your anterior guidance or canine guidance has to be steeper. What do we know about steepness of guidance? If somebody has very steep guidance, that puts stress into the masticatory system. So all the time we're looking to try to get guidance which is as shallow as possible, but still discludes the posteriors. And we have to give a little bit of leeway, maybe about 1 millimeter of disclusion. So it's all a matter of trying to get something which is comfortable for the patient. Ideally, it's shallow guidance at the front, it's shallow cusp angles at the back. And that will give more longevity to the restorations and make a more comfortable masticatory system. Next question. How do you determine the lateral guidance angle? Hopefully I've done that on the articulator. Yeah, well, we have to set it so that the posteriors disclude. So we don't set it to any degree. Okay, when I go and take my mounted study cast, I'll take a protrusive check bite. I won't do laterals, I'll take a protrusive check bite so I can set my condylar inclination. We know that my lateral inclination will be just a touch steeper than my condylar inclination. So I set my condylar inclination. We then put our guidance in place, the shallowness or steepness, so it discludes the posteriors by about 1 millimeter. We then go and put that into our prototypes. We put that into the mouth to make sure it works. And if it does the discluding by 1 millimeter, that's fine. If for whatever reason we've got it wrong, we then need to either shallow it or build it up until the stage where it discludes by 1 millimeter. And once we've got that, then we're waiting for our patient to get comfortable. And if our patient's comfortable with that, great. And when we're talking comfortable, we're talking about comfortable in the jaw joints. If the patient's not comfortable in the jaw joints, it means the steepness is too steep. What do I have to do now? If I shallow the steepness, it means that I'm going to get non-working or balancing side interferences. So I have to go to the back of the mouth, shallow cusp angles first of all, and then shallow the guidance until it's comfortable. Okay, I hope I've answered that one. And the next one. When we have implants on canine premolars, we give group function to prevent overload. Won't this cause class 2 leverage, sir? Yes, we have degrees of class 3 and class 2 leverage. So class 3 leverage doesn't suddenly change and become class 2. So we have class 3 here. As we go further and further back, we don't have anything called class 2.5 leverage. But if you can just get this thought process, that here we have class 3, there we have class 2. In between class 2.5 leverage, I know there's no such thing, but think about it. Further back, then our forces start to increase. Okay, and ideally we want the forces as far forwards of the condyle. Okay, so this is our condyle, this is our fulcrum. Imagine the nutcracker effect. Nutcracker effect is our class 2 leverage. Okay, if you want to break the nut, where do you put the nut? You put it right next to the fulcrum. You put your hand grip as far away from the fulcrum as possible, leverage, the nut fractures. In this instance, what we're talking about is not nuts, but teeth, and we don't want teeth to fracture. So if you go and put your guidance right next to the fulcrum, increase stress on the teeth, brackets nuts, nut fractures, teeth will fracture. Okay, how do we create class 3 leverage? We change the position of the hand grip and the nut. So instead of the nut being at the fulcrum, we put the nut as far forwards as possible. Instead of the muscle group being a long way away from the fulcrum, we put the muscle group closer. So now we have class 3 leverage. And with class 3 leverage, our nuts, our teeth hopefully do not break. So think about class 3, class 2.5, class 2 leverage. Okay, next one. For patients having open bite to determine anterior guidance. Okay, so interesting one. Anterior open bite. First question is going to be, can I eliminate the anterior open bite? And if I can, I want to do that. Orthodontics, orthognathic surgery, bring the mandible forwards and upwards. If I can't do that, then maybe sometimes we go to a Pankey-Mansheiler style of occlusion, which is a long centric, so that if my anterior teeth are out of contact by that much, we put a flat occlusal plane on the upper posteriors. So the lower buccal cusp slides on the posteriors by exactly the amount that the anterior teeth are out of contact. And then when the anterior teeth do come into contact, they then take over the guidance. So we could do something with a long centric. Otherwise, we try and build up the lower incisal edges, build up the palatal aspects, as I showed in the canine to canine bridge. But somewhere you want to have the guidance as far forwards as possible. Okay, next one. Views on increasing OVD beyond 5 millimeters might cause constriction of airway space. Should it be considered when determining? As far as I'm concerned, no. We've got pure rotation happening for the first 10 to 15 millimeters, and then it's translation. The most I've opened somebody up by is about 1 centimeter. I don't feel that there'll be any restriction to the airway. So for me, no. 5 millimeters is my sort of standard so that patients can actually look better. But anywhere up to 1 centimeter, I'm very, very comfortable. Views on sleep apnea and snoring, anterior positioning, and their effects on TMJs. Okay. We have two opposing problems here. We have bruxism and we have sleep apnea. Sleep apnea is probably more threatening to the patient's life, but if we do bring the mandible forwards to open up the airway, then our condyles aren't in a good position and we can start to get TMJ problems. So there's no, as far as I'm aware, there's no solution to that at the moment, other than potentially wearing them alternate nights or looking at which is the major factor, which is the major problem for the patient. Is it bruxism, TMJ problems, or is it sleep apnea? And treat which is the worst problem. But to me, the two things are completely opposite. They're polarized. You treat one and the other becomes a major problem. Treat the other and the first one becomes a major problem. Okay, next one. Will canine eyes not break over a period of time? It will wear down. Of course it does. But you're buying your patient time. So you have to say to your patient, if you restore that with ceramic, it probably won't break down. It might wear the lower tooth. If you do it in composite, yes, the composite will fracture. And we're not talking about saying to a patient, this is going to last you the rest of your life. With composite, we're saying to the patient, you have a problem. Remember, it's always the patient's problem. Do not take home the patient's problem. Do not absorb them. You are here to give the patient options for treatment, which he then decides. First option, do nothing. Okay, wait, your teeth will wear down, they'll fracture, but that's an option. Option number two, cheap. Let's go and put a canine rising composite. It will last maybe 3-5 years, something like that. It will then need to be replaced. Make sure you understand every time you replace it, I will be charging you the patient money. It is your choice to have this done in composite. It will wear and it will need to be replaced. Okay. If you don't want to have it replaced, then have the composite and have an occlusal splint made. The occlusal splint will cost you a lot more money, but it will stop the composite having to be remade. If you don't want the composite remade as often, choose ceramic. The ceramic will probably last you 15 years, but it will ultimately, it will need to be remade. If you don't want the ceramic to be remade as often, have an occlusal splint. So we have different levels of treatment, going from cheap and cheerful, which gets you out of the problem now, to more expensive, longer problems. And it's a matter of you discussing this with your patient. Next one, I think it's the final one. Vertical dimension collapse during sleep. How can you rectify that? Or spouting while sleeping. I have no idea what you're talking about when you say vertical dimension collapses during sleep. Okay, it can't collapse. Your teeth are there to stop it collapsing. So I don't really know what you mean by vertical dimensions collapsing when you sleep. Sorry, I can't answer that question. Okay, guys, I think that is all the questions that are done with. Again, thank you very much for your time. It has been People asking, will this stay on Facebook or will be deleted? That's down to you. It's nothing to do with me. Please visit the Tipton Training website. Please sign up for our free webinars. We are here to help the profession worldwide. Tell your friends. We're going to be putting webinars. We've been doing this for the last 6 weeks. Webinars every single day, sometimes twice a day. Keep well, stay well, and I hope that we see some cricket coming from India shortly. In the meantime, thank you very much for your time and attention. Goodbye from the UK.